Hi everyone, my name is Cynthia Tran, and I am going to be presenting about my project this semester, which was about reducing cesarean section rates in low-risk pregnant women. So this problem is significant because cesarean sections are associated with an increased risk of complications for both the mom and the newborn. Here is a list of some of those examples of complications, such as neonatal respiratory distress syndrome, adverse cardiovascular events, postpartum depression, infection, hemorrhage, organ damage, extended recovery times, and anesthesia-related complications. However, despite all of this, the primary C-section rate increased in 2019 from 21.9% to 22.4% in 2021 in the United States. A specific hospital in Southern California has the goal of reducing the primary C-section rates for low-risk pregnant women from 16.4% in April of this year to 12.3% to reflect on the significance of reducing complications related to cesarean section. This proposed project has different enhancers and detractors that will affect their success. For example, there has been an increasingly positive attitude towards non-pharmacological pain management with labor, and the potential for reduced complications is also a plus. However, it is difficult to provide education to a mother who is already in labor and in pain, and there may be providers who are reluctant to change their current practices. Furthermore, there may not be enough resources, or people do not know how to access resources about pregnancy, labor, and delivery. And so the change theory that I will be applying throughout this project is Lewin's change theory, which involves three phases. The first is the unfreezing phase, which is the agitation of equilibrium. So identifying stakeholders is really important in this phase and really motivating them towards the need for change. Phase two is the change phase, which is the one where we move employees to a new equilibrium by helping employees to view change from a new perspective and helping them to work together to achieve desired outcomes and facilitate consistency in maintaining those outcomes. Which leads us to the last phase, which is refreezing, which involves the integration of new behaviors and desired outcomes into the organization. And the PICO question for this project was, how does patient and staff education about alternative birthing positions compared to standard care affect cesarean section rates in low-risk pregnant women at a Southern California urban hospital birthing center over the span of 2 months? The review of literature was conducted using Google Scholar and PubMed, using the key terms that you can see on the screen here. The key terms included reducing C-sections and very similarly reducing cesarean sections, alternative birthing or labor positions, which is one of the key things that we will be using throughout this presentation, as you will see in the implementation plan later on, promoting vaginal delivery, labor position and duration of labor, hands and knees position, fetal rotation, and peanut ball, which resulted in a lot of evidence surrounding the use of alternative birthing and labor positions and the reduction of CS, or cesarean sections. I want to start with some randomized controlled trials and a retrospective cohort study that stood out. So a lot of the evidence surrounding some of the things about alternative birthing positions seem contradictory. However, the more recent studies show an overall positive support for the use of alternative birthing positions, and these things called peanut balls, which you can see on the right of the screen. So peanut balls are peanut-shaped exercise balls that are used for women who have received an epidural to help in labor positioning. And one randomized control study showed that pregnant women who used peanut balls had a reduced labor duration and CS rates, whereas another study with insufficient power showed that there was no significant difference. There was also a retrospective cohort study that looked at the use of peanut balls and found a positive relation between their use and the number of vaginal births. And the same goes for the alternative labor positions. There were a lot of studies, and here on the screen specifically randomized controlled trials that looked at labor position and the effects on fetal position during labor, which will affect whether or not a C-section is needed. And so one study looked at which was a multi-center randomized control study, looked at hands and knees position versus a control group and found no significant difference. Whereas another study in 2018 showed that women who chose the most comfortable position, except for a lateral position, had significant difference in fetal rotation during labor. There were also several systematic reviews and meta-analyses. One conducted in 2023 looked at alternative versus supine positions and their impact on CS rates and found that supine positions increased CS rates. Another older study looked at a broader overview to explore several strategies to reduce CS rates and found that multifaceted interventions effectively reduced rates, which will come in handy with our implementation plan later on. And then another study looked at the effect of prenatal education on CS rates to provide information to support and guide prenatal education. Several qualitative studies also were used to look at the experiences of both mothers and maternity care providers. And so one study that was published in 2023 explored the experiences of mothers with alternative birth positions and found that mothers who were provided with education regarding alternative labor positions had better birthing experiences. And another study in 2020 looked at the experiences of both mothers and maternity care providers to identify barriers to vaginal births. And the key terms that came of this showed that barriers included, quote unquote, the climate of restriction, fear, and discourage, insufficient encouragement system, and unsupportive birth team. And so from this, the recommended best practice is to promote strategies that promote movement during labor. And so again, we look at the alternative birthing positions that improve maternal satisfaction and reduce CS rates. And some of these positions include modified Sims positions and hands and knees positions. And then we also look at peanut balls to reduce labor time and CS rates to help promote different labor positions and movement during labor. And the policy and protocol for change will be in the next couple of slides, but overall, they include physician, nurse, and patient education, which looks like training that can be provided through an organization called Spinning Babies. And so Spinning Babies is a org that can provide courses with the goal of working with the physiology of the mother and new alternative birth positions to quote unquote make room for the baby. And then another part of our policy and protocol will be disseminating resources to patients so that they understand what is available to them in the community with prenatal education, as well as when they are admitted to the labor and delivery room. And the factors that will really facilitate change at this point is making sure to identify stakeholders, which include our nurses, physicians, and the patients, and motivating them to work towards behavior change, which ties in the Lewin's change theory that I had mentioned earlier in the presentation. And here is the policy showing that nurses and physicians will be providing patients with information prior to and during labor to promote the use of alternative birth positions, including the use of peanut balls to promote vaginal delivery. And this is the protocol, which is broken down into 4 phases, the last of which is the evaluation and the rationales that go with it. And I will go into these phases in a little more detail in the next slide because that will be our implementation plan, which includes a Gantt chart. So this chart breaks down the phases once again, but also includes the start and end dates, as well as the team members who will be responsible for each of the tasks. So we start here with phase one, which is community education. And I believe that this is the most likely to succeed because when patients are prepared, they are better able to hopefully advocate for themselves and their baby. And so phase one involves the compilation of community and hospital resources and their distribution to staff so that they can be disseminated to patients during their prenatal visits as well as during their hospital stay. Phase two involves floor nurse training, which will include providing presentations to floor nurses during their morning huddles to encourage them to promote movement during labor. And this will involve a lot of motivation as well, because when nurses understand the impact that they can have on the mother, the baby, and the outcomes of the labor experience, then they are more motivated to implement these strategies. And then this phase will also include scheduling and providing opportunities for floor nurses to participate in the spitting babies courses that I had mentioned in an earlier slide. Phase three involves physician training. So this involves providing physicians with information, again, about the risks associated with cesarean sections and the literature supporting the use of alternative labor positions in peanut balls. And then I will go into our last phase in a couple of slides, but first I want to talk about the potential consequences of the three that we have discussed so far. So in phase one community education, there is a possibility that the physicians just don't distribute the list of resources, or that patients who do not receive routine prenatal care are never exposed to the resources in the first place. And so it's important here to provide similar information in the hospital setting. However, we do have to keep in mind that this may not be as effective as an effective strategy because there is that reduced ability to learn when the mother is in labor and already in pain. Phase two and three, the potential consequences are that the nurses and physicians need to take the time to really engage in the presentation. And so this will involve some input from them, as well as costs associated with providing training, especially bringing in another organization like Spinning Babies. And this brings us to our evaluation plan. So recall that the goal of this particular Southern California Urban Hospital, their family birthing center, was to reduce the cesarean section rate from 16.4% to 12.3%, according to their director of the family birthing unit. And so these rates should be tracked throughout the implementation phase, which, if you recall, was about 2 months. It was a 2-month plan. And so to do this, staff surveys and audits for use of alternative birthing positions, peanut balls, and CS rates will be conducted through surveys for floor nurses that will be done before and after the implementation plan. Furthermore, CS rates will be tracked, CS rates for low-risk pregnant women will be tracked throughout, and the director of the Family Birthing Center will be responsible for this part of the plan. Lastly, feedback will be provided by the director of the Family Birthing Center to the managers for dissemination to the staff about CS rates, the use of alternative birthing positions, and peanut balls. From here, the plan can be reevaluated and different approaches can then be implemented. For example, there are a lot of other research about nitrous oxide that could be implemented. And just a note on nitrous oxide, this was something that this particular hospital had used previously for pain management. However, with COVID-19, the use of nitrous oxide was discouraged because of the potential for respiratory infections. And there is here a whole list of other things that can be, other alternative approaches that can be considered. And with that, I want to thank you for participating in this presentation. And I want to say a special thank you to my preceptor, Ray Ann, for her support and her guidance throughout this project.